Hello and welcome. Welcome to this IFSO APC webinar brought to you with our educational partners, Johnson & Johnson Meditech. Good morning, good afternoon, good evening, depending where you are in the world. Thanks for joining us. My name is Ahmed Ali. I'm a surgeon in Melbourne and currently the president of IFSO APC. We have a couple of wonderful speakers and a strong panel for you gathered tonight to discuss the advances in stapling for metabolic and bariatric surgery. And so I'll do a brief introduction and then we'll get into the program. Our first speaker tonight is Dr. Shashank Shah. He's from India and is the past president of the Obesity Surgery Society of India. He currently works at the Lapro Obesity Centre in Pune in India. So welcome, Dr. Shah. We also have Professor Tammy Kindle with us. Tammy is the Professor of Surgery at the Medical College of Wisconsin and the Director of the Bariatric Surgery Program there. She's the Chief of the Division of Surgical Research and serves as a board member on the MBS. So welcome, Professor Kindle. Thank you. And then we have a couple of our panel members from the APC region. We have Suthep. I'm sure everyone knows Suthep very well. He's in Thailand. Suthep is the Professor of Surgery at the Faculty of Medicine in the Chulalongkorn University in Bangkok and the Director of Obesity Care at that hospital. He's currently the President of the Thai Society of the Metabolic and Bariatric Surgery and is the President-elect of IFSO APC. So welcome, Suthep. We'll be looking forward to some interesting discussion with you as well. And we're very happy as well to have Professor Sung-Hoon Kim from Korea. He's the Professor and Chairman of Surgery at the Seoul University Hospital, where he also directs the Bariatric Surgery Center and is currently the chair of the Scientific Committee of the Korean Society for Metabolic and Bariatric Surgery. So thank you for joining us, Professor Kim, as well. Just for all the delegates, this webinar is being recorded and the recording will be available about 24 hours after the conclusion of the webinar on the IFSO Virtual Academy. We'll have the presentations and after each presentation we'll have Q&A. If you look at the bottom of the screen, there's a Q&A tab and you can list any questions there and hopefully we'll get round to addressing those questions. But let's get on with the program. We'll start with the first presentation this evening from Dr. Shah, which is looking at the science of stapling and the fundamentals with tissue interaction. So Dr. Shah, I'll ask you to give out your presentation.
Greetings from India. I must thank IFSO APC for this opportunity and this invitation to speak on advances in stapling for metabolic and bariatric surgery, talking about engineering and surgical precision. Now, it's been almost 22 years of bariatric and 15,000 plus procedure. For any resection, anastomosis or everything, probably use of stapler has become a norm. We all know the burden of obesity, burden of diabetes in Asia Pacific region and the rising volume of metabolic and bariatric surgery in spite of the newer anti-obesity medication. Staplers are here to stay and critical and central to metabolic and bariatric surgery. Staple line integrity directly determines the risk of anastomotic leak, bleeding, comfort of procedure, time of procedure. And I remember at times when we used to be taught about corneal suturing, inverting the mucosa, angle of sorrow, then take a stitch at the angle of sorrow. I believe that staplers have removed all that fear. Now, instead of that angle of sorrow, if you do a functional end-to-end anastomosis, there is no angle of sorrow. Staple line leaks definitely account for majority of the complications and therefore one must know everything about the mechanism of stapling, how to choose a stapler. The evolution started with mechanical or manual operated staples where there was limited articulation, a fixed gun and fixed jaw, and then the surgeon had to use his force. Then came laparoscopic linear cutters. We all still use them sometimes, but forward gun definitely made a difference with consistent firing force. There is no lateral movement while you fire, tissue adaptive technology, and greater control on staple formation. The next generation powered articulation, real-time haptic feedback, and maximum jaw opening. That has made a difference, and jaw opening definitely matters. Now, how are staples formed? The mechanics is staple starts as a thin titanium or stainless steel wire. We prefer titanium with a preformed shape into a B shape within the cartridge. On firing, the anvil folds the B shape down, compressing the tissue in between, and then that forms a suture or a titanium staple. Closed staple interlocks to create a secure hemostatic tissue seal at the same time preserving blood supply. So staggered rows ensure overlapping compression times and minimizing the leak. Of course, still there is blood supply preserved. Cartridge and anvil interact with each other. There is uniform compression and the gripping surface technology which I'll talk about forms a better B formation. Now, during firing, the beam advances simultaneously, cutting and stapling. So, three rows on either side, and there is uniform compression. Closure force distributes evenly across the stagger rows on either side. Powered firing definitely has a consistent, controlled, and uniform force without any movement, and regardless of tissue density or visceral fat. So, no manual force is required, and it is better controlled. Now let me show you how staples are formed. This is how the blade is getting advanced and the drivers are pushed ahead, firing the advances and the closure force distributes evenly and then a B formation and then compression happens. Now, how is staple thickness decided? We know the thickness varies from tissues, from mesentery, fat, stomach. Stomach thickness varies, antron is thicker, body is lesser thicker, maybe fundus is still less. Operated tissues, scarred tissues, previous scarring can make it thicker, more tough, and therefore tissue thickness should govern the staple height. There are various color coding for these tissue thicknesses. If the tissue thickness is too thin, you see this. If the tissue thickness is too thick, probably the formation may not be complete. Therefore, appropriate choice is important. Now, this is gripping surface technology. While I am showing you a video, you can see here as the B advances and then it is compressed, a uniform gripping surface on the anvil makes the formation much better. You can see here in the other slide. So this is a gripping surface technology, a definite advantage. Now, with higher visceral fat, fibrotic tissue, vascular tissue, each one needs a different thickness. Definitely for any redo, stapling over stapling, then some areas where tissue thickness is very high, maybe higher staple height is required, and for the very thin one, vessels, maybe minimum tissue thickness is required. Now, surgical precision, access, articulation, and control. As we know, all challenges of patients with morbid obesity, maybe Asian, Indian patients are sometimes short, so the space inside may be narrow, the mesentery may be thick, fat laden, and to open the stapler inside, you need some space. Higher BMI patients need a different articulation, different ergonomics altogether. In such cases, powered articulation definitely helps. One-handed control, you can articulate the gun anywhere and then you can close. Better jaw opening makes it better and it enables precise judgment, precise engaging of the gun on the tissues and you get real-time feedback in today's staplers. Sometimes the gun does not close, finds it difficult to close, or you get an audible or a tactile feedback, and this can be even digitally enabled, and that is important when you form a stepper. Now, the access challenge, this is what I spoke about. Robotic surgery and intelligent stapling. So now the stapling is becoming more robotic. Robotic stapling uses purpose-built wristed cartridge gun systems validated for robotic articulation. Now there are Lot of advantages of AI-assisted tissue sensing, intelligent firing, and data collected through retrospective analysis of all the firing. And then that can advance us to the next stage. Robotic is definitely picking up, but still, majority are still using the powered articulated guns. Now, this is about Echelon 3000 powered stapler, and this is a 360 full shaft rotation, stagger stepper rows. So, Echelon powered firing with articulation with GST staples. Probably this is our best standard as on today. Even though this is an Ethicon sponsored meeting, I must say majority of our procedures are with Echelon 3000 gun. Now, stapeline malformation and causes. What is a malformation? A failure of a complete B or a distorted staple. When? When does it happen? When the staple does not close uniformly. One or both legs of the B remain open like this, and this can increase the risk of leak. Now, malformation can happen because of tissue over-thickness or maybe very thin tissue, maybe inappropriate choice of a cartridge, very scarred or very thick tissue, or sometimes when a surgeon tries to use one cartridge with some other gun. There are two types of staple formation. One is the consistent staple formation, and there are variable height staples, which is getting advanced. So the advantage of variable height staples is there is something for hemostasis, there is something for better grip, and this debate goes on. Cartridge gun interface is important. The cartridge must be precisely matched to the gun handle, a lock mechanism. Mismatched systems can result in partial firing or misfiring, incomplete staple row deployment. So one surgeon has to make sure that the cartridge locks in with the click, the choice of cartridge is perfect, and the same company or the same cartridge is used for the same brand. And that can probably prevent most of the accidents. Very few accidents, maybe one out of 10,000, but it can very easily be managed if the suturing and the knowledge of stapling is very advanced. There was one study done from our unit randomized control trial for using staple and reinforcement and suture process. There was no difference. And today's advanced GST stapling technology with articulation with guns, probably there is no difference. However, in our practice, we still suture oversew the entire staple line. Rollins did another study where it showed efficiency of powered echelon gun. And IFSO APC 2021 report shows growing need for metabolic and bariatric surgery and greater use of staples here. The future design is going to be more interesting. It is going to be tissue sensing technology, auto selection of staple height, auto selection of closed loop feedback when you get it, AI driven arrest of firing when the thickness is too high, digitally connected platforms, so smart tablets connected to OR information system, absorbable staple materials, biodegradable cartridge, and that probably would be the future provided it is cost effective and timely done. So there are some reverse staplers or retrograde staplers which we have seen. Sometimes maybe we might have seen in college staplers, they are still under development. They eliminate the need for instrument repositioning. Clinical use cases, posterior sleeve closure, reaching posterior gastric gauge without repositioning the stapler or retracting the bowel. So there are different advantages of a reverse stapler. Engineering and safety considerations are important, so the designs are in making, but I believe reverse stapling, probably Colles gastroplasty, is the best indication where from fundus to the body one can fire. So after almost more than 15,000 procedure, I believe that stapler is extension of my hands. Suturing. All the suturing is done with staplers except for maybe the enterotomies, but there could be totally staple closure as well. Staples save time, minimize bleeding, there is early recovery. I believe the incidence of leak definitely has reduced because even a junior can fire a stapler, and I believe that stapling advances has definitely advanced metabolic and bariatric surgery, made it much safer, Stapling precision, choice of stapler, choice of the type of gun, or maybe powered gun, articulated gun, AI feedback, tactile feedback, probably all together can make metabolic and bariatric surgery much safer. And as we know, the data says that the complication rate is as much as that of a normal delivery, and we try and make it as less as possible. Thank you.
Thank you, Dr. Shah. I think we can go to some questions now from our panel. I've had a quick look in the Q&A. I don't see any questions from our delegates, so I might start things off. Dr. Shah, you talked about staple height choice and you talked about different thicknesses of tissue. How important is compression before firing?
Yes, that's a good question. So it's staple height, staple compression, uniform compression all throughout is important so that tissue is expelled and the grip on the of the B formation on the tissue is formed. At the same time, compression has to be managed between hemostasis and maintaining microvascularity. So it's a balance between the two because blood vessels have to pass through the B, and it's a balance between the two. There were more compression forces or reinforcement materials used. However, just now our three-row standard staplers do achieve optimal compression and staple formation.
Yeah, so but what I'm wondering about is when you apply the stapler and you compress, often you can see edema coming out of the tissue. You see some fluid moving. So is it good to just put the stapler on and fire straight away, or do you need
Oh,
some
oh,
time of
got it, got
compression?
it. I,
How do you judge this?
we close the stapler and we wait for 30 seconds by watch by the anesthetist and then fire slowly. So waiting for some time does give enough time for tissue to be expelled. And then the compression becomes more uniform and better. Very good question. Thank you, Ahmed.
That's okay. That's fine. You mentioned reinforcement. Many surgeons use reinforcement, many surgeons don't use reinforcement. What is the purpose of the reinforcement? You already talked about the staplers forming very uniform deployment, good shape of the staples. They're staggered, they're not all in one line. What role does reinforcement play in forming the staple line?
That's another good question. So addition of a reinforcement material does improve compression and it has benefit in minimizing the staphyline ooze or staphyline bleed. However, there was no difference in the rate of leakage in all the randomized controlled trials. So it's just an additional reinforcement. It could be material, bioabsorbable material, it could be glue, it could be suturing, it could be clips. All of them probably add an advantage of minimizing the stapler line ooze. The surgeons generally like to see a dry stapler line.
Yeah, we do. We don't like the ones that ooze. If there's a little bleeding point, that's easy. You can put a stitch. But
Yes,
when
it
it's
is.
oozing,
Very true.
that's not nice. And if you use some reinforcement, if you use, seam guard or whichever type you like, do you need to add staple height? For example,
Yes.
if you're just stapling the tissue and you think, for example, an echelon blue cartridge is correct, but you're using reinforcement, should you change the color?
I think you need to go one level high in the staple height because even though the reinforcement material is very thin, it does add some more diameter, and therefore we generally step up to one more level if you are using a reinforcement material.
Okay. All right. Any other questions from the panel? Sang Yun or Suthep?
Yeah, I have. Can you hear me?
Yes.
Yes.
Yeah. Thank you for your great lecture. The the very informative lecture. So I have two questions. First question is about staple height. Personally, I routinely use the thickest uh, stapler, such as black stapler, for the first one or two firings, and the second thickest stapler for the rest in the sleeve gastrectomy, regardless of patient factors. So, do you customize stapling height based on patient characteristics such as BMI or sex or age?
Very, very useful question. So there were studies in which the stomach thickness was studied in the fundus, antrum, and in the body, and the antrum was found to be thickest. If you are going very, very close to the pylorus and you're looking at doing total andrectomy, the thickness is highest, and in those cases, maybe a black cartridge can be useful. At the same time, I can always say if you use a bigger staple height, the chances of bleeding. You should never choose a lesser height because sometimes a malformation can be there. But in most of our routine cases, the first firing is about 4 to 5 centimeter proximal to the pylorus, and green, purple, or any equivalent can do the job well, except for patients whose BMI is more than 60, those who have some kind of gastropathy, some kind of previous operation infection, where we find the antrum unusually thick, then in those cases, maybe the first firing is with the black cartridge. And this probably could vary based on ethnicity, patient size, patient's type. But this is what we generally follow. It's almost more than 4,000 sleeves and maybe since 2005. And all these cartridges have done very well. Only thing, in very few cases, we use the first cartridge as black. But whenever you close a gun, if there is resistance in closing a gun, if you find that gun closure of the gun is little harder, and then you open it, you withdraw the gun a bit, and then refire, and make sure that too much of tissue at the angle is not there. If still the thickness is more and you find closure slightly difficult or more resistant, one can step to a higher level of staple, and that use a black cartridge.
Oh, thank you. I have one more question. Some
Yes, please.
staplers can control the speed of firing. In my experience, a slower firing speed clearly reduced bleeding. So, is there any evidence on how firing speed affects bleeding or leakage? So, what is your personal opinion or experience?
So if you're using a staple where there is a uniform compression and complete closure at the same time, just like echelon, we use for 30 seconds before firing so that entire tissue is expelled. However, there are guns with sequential firing. So the compression goes on increasing as you keep on firing. Then you make the first one third of firing. You wait for 10 seconds, then progress, then wait for more and more compression till it reaches the tip. And this is how we decide the timing based on the technology used by a company in stapling.
And I think this is a very important point because different people will use different staplers. You need to understand the mechanics of the stapler you are using. So, like Dr. Shah said, the echelon stapler applies pre-compression. So when you close it, that is the compression. It does supply a little bit more as you fire, but most of the compression is when you close the jaws. There are other types of staplers, the tri-stapler. There is not very much pre-compression. The compression happens as you fire. So you need to understand the mechanics of the stapler that you're using in order to use it correctly. So this is a very important point. So Thep, do you have any questions or comments for the panel?
Thank you very much, Shashank. Very informative. And you have reviewed from manual to power, and then next then So I agree with Ahmed that we have to know about the mechanism, how to use the technology applying to the patient. Shashank, could you give us your insight and your rationale to, for doing for the last stapler that you have to fly at the angle of his? So how you advise those, junior or other people to make a decision making to apply another one, or that stapler it's secure enough to use scissor to just cut that part. Your advice.
Very, very interesting question. And surgeons always tend to save some cartridge. My advice is never to do that. Use the last cartridge, examine under magnification. Unless all the three staples have crossed the distal edge of stomach, we don't call it firing. Sometimes we see that two staples have crossed and the middle one is there. And maybe my associates are tempted to use a hemoclip or a clip or a suture, but that's an angle which is very risky. One more cartridge is worth it if you can save someone's life and morbidity. So, my advice to everyone is maybe you use another cartridge if all the three staples are not beyond the distal edge of the stomach's curvature. This is what I follow. Of course, sometimes a clip can do, but that's not my recommendation, especially for the juniors. And I missed this point, Sutep. Very important for safety. All those who are beginning should know this point. Do you agree to this?
Absolutely. Thank
Yes.
you.
Spend the $200. It's better. We do have a question from the floor, actually, so I'll read it out and maybe I'll throw this one to you, Tammy. The question is, in sleeve gastrectomy, stapling with reinforcement like seam guard, can it affect a redo surgery later, like a Roux-en-Y bypass? Is it harder to make the pouch?
I think that's a good question. And having used a couple different types of staple line reinforcement, I do think that there's more scar formation to that staple line when you go back to do a revision. And so the dissection of the lateral aspect of the staple line is maybe a little bit more tedious. I would say most importantly, particularly if it's a revision of a sleeve and you haven't done the case, is to look for clips. So staple line reinforcement doesn't bother me as much whether they've used it or not. You'll get through that dissection, but having a meticulous view of that staple line to make sure where you come across with your horizontal stapler that they haven't used clips to reinforce their staple line, because that certainly is going to cause a staple line malformation.
Yeah, I think that's a very good point. And I think that's also just a good point to think about in your own technique for primary surgery. Always imagine that you might be coming back on that patient and think about what will be helpful or what might be difficult in that situation. Always think about what might be needed next time. Of course, you need to do what's safe and what is good in your hands, but we should try to develop techniques that allow us to come back later without too much danger. That's always something I think it's worth thinking about. All right, well, look, we might move now on to the second presentation and invite Professor Kindle to present on some of the more recent, the latest technology, what's on the horizon in the stapling arena. Thank you, Tammy.
Hey, everybody. My name is Tammy Kendall. I'm a bariatric surgeon in Milwaukee, Wisconsin, and it's my pleasure to present to you on this webinar the latest stapling technologies. I do have a disclosure. I do educational speaking and consulting for Johnson & Johnson. I am going to try to stay agnostic to manufacturer during this presentation. There are a lot of technologies available that have stapling advantages, and most of what is presented in this presentation are the benefits that are being claimed, not necessarily backed in clinical studies by the manufacturer. And due to time limitations, I certainly can't present every manufacturer and stapling technology available. And I don't want that to be interpreted as a statement of support or superiority for one particular device. The goal of any technology is to provide better performance enhanced reliability of the device, and value to the patient, surgeon, and healthcare system. So why continue to advance? And I'm going to show you 2 videos here of staplers performing imperfectly. These are both my cases. Different stapling manufacturers, so you can see nothing's performing perfectly all of the time. This is a sleeve to bypass here. And as we come across the sleeve, the tissue not overly thickened, using a gold load with the stapler, and we had a completely malformed staple line. Not a single staple was pushed forward on the superior 3 rows of the staple line. Interestingly, on the sleeved remnant, all the staples were intact. The second case is on a robotic platform, and here we have a primary sleeve gastrectomy. And going along our fires, this was the 4th fire. You can see we're getting some compression and smart technology feedback about the firing not going well. We watch the tissue push out here, and you can see just about half of the entire 60 millimeter load was malformed with a staple line dehiscence. So we have work to do. What is the cause of why we can have challenges with the staple line, and what can we do in terms of technology advancements to try to improve this? And so the tissue needs to be stable within the jaws of the stapling device as the blade moves forward. And this can get malpositioned when we have inappropriate selection of stapling height to the tissue thickness. If the channel itself, as you can see there, gets laterally deflected, the lateral aspects of the staples will not hit the pocket and form a B staple. The anvil itself can be misaligned, also missing the pocket when the staple goes to form. And here's just an example of how important hitting that pocket is for appropriate B staple formation. So we're going to go over a couple different things that have advanced in terms of stapling technology. Both staples and staple line formation have changed. Smart technology and feedback from the instrumentation itself. Changes in grip strength, post-firing reinforcement, and then continuing smaller footprints of the stapling devices. So in terms of staple formation, the kind of standard traditional 2D reload that you see in the lower right corner has been what has been present for years. And recently, Ethicon did come out with a change and the closure of the staple legs, so that rather than being linear, you can see particularly here how there's a offset of the staple legs, and the manufacturer suggests that this can evenly distribute compression across the 2 layers of the tissue, and that could reduce potential leak paths as you get staple closure and healing. This is technology advancement courtesy of Medtronic. And so Medtronic is looking at varied staple height, and it's designed as a stepped cartridge face. Again, per the manufacturer, they believe that this delivers graduated compression. You can kind of see how this happens in a graduated rather than a more standard fashion across the 3 rows of staples. And they believe that that helps generate less stress on tissue during compression and clamping. The manufacturer does describe the graduated compression profile and varied height of staples, also allowing greater tissue perfusion into the staple line. And it is believed that having perfusion at the end of the staple line is important for ultimate healing. This is related to smart technology. So there's a couple different manufacturers who are using smart technology, just to mention Medtronic and Intuitive. This is a graph that's provided by Medtronic, but I think this applies to multiple manufacturers who are trying to use smart technology, mostly related to the firing speed and to give feedback to the surgeon potentially about tissue thickness. If we look at the lower left-hand side of this graph, with less thick tissue, slow speed versus fast speed, in general, you see a very high percentage rate of formed correctly staples. But where we get into a problem is with increasing tissue thickness without appropriate compression and maintaining high firing speed, an increased percentage of malformed staples. And so both of these technologies are trying to slow down the speed of firing, allowing for tissue compression, even at times allowing for pauses within firing to allow for more tissue compression, and slowing down the firing speed so that hopefully you have a much higher percentage of appropriately formed staples. I'll just take a second to mention we're only as good as what we do with our smart technology, and no different. You know, sometimes we get feedback from the instrumentation telling us to do something or change something, and we think we know better. And so do you listen to your smart technology? What would it take for us to be better at listening to that smart technology and altering our surgical technique with the feedback that we're given? Grip strength is also a really important component of correctly formed staples. And this is the concept that the tissue inertia is what allows the knife blade pushed by the sled to move forward through that tissue, divide the tissue, create the correct formation of the staples, and not have a tissue push out event. And so there have been some advancements in grip strength and how the stapler actually is trying to hold inertia of the tissue, recognizing that matching tissue thickness with the correct load is an important part of this. So this is some tissue that has radio labeled blood vessels, where you can actually see what happens to the tissue as the stapler engages. And here is this just looking in slow motion. So you can really imagine how a push out event might happen. And as that push out happens, the staples are not hitting the correct B staple formation. Ethicon has introduced what they're calling GST, Enhanced Gripping Surface Technology, again, trying to maximize inertia of the tissue so that as the sled pushes the staples forward, then followed by the knife blade, that you have stability of the tissue within the stapling device. And then smaller footprints is always a moving target. So Intuitive has an 8mm stapler, recognizing that as your footprint gets smaller, the number of staplers, the staples that you can have in rows often is compromised. And so this is a 4-row stapler. Hologic also has what they have named the Just Right stapler. This is a 5mm stapler. Again, 4 rows of staples. And I think this is a balance as we move this technology forward. A smaller footprint is ideal in terms of reducing incision site, potential hernia formation, postoperative pain, potentially working in smaller spaces where the large head of a 12mm stapler, or certainly even the larger staplers, may not be able to maneuver in a small space. But we don't want to compromise on staple line integrity. And so as we go down on rows, right, so we went up on rows to try to improve integrity, decrease bleeding. As we go down on rows, we really have to make sure that those other components, 100% correctly formed staples, making sure that you have good coverage of those two staple lines, good grip strength, potentially smart technology as well, are being utilized as we step down on the rows of staples being used. Now, staple line reinforcement has been around for a while, and this is maybe the one that actually has some literature supporting or not supporting technology. The concept of staple line reinforcement is to have increased burst strength, so you need higher pressures to compromise the staple line, which theoretically would decrease primarily bleeding, although potentially leaks, and then interventions needed for bleeding. Just to highlight, you can pick your study you want from the literature supporting or refuting the use of staple line reinforcement. This was an MBS QIP analysis, and in this entropy balance analysis of the data registry, you can see there are over 280,000 patients. It was supportive of staple line reinforcement for lower postoperative leakage and bleeding, particularly in sleeve gastrectomy cases, both on the robotic and laparoscopic platform. So what's next? Well, we've already seen come on the market single fire staplers, really designed precision for specific procedures. This concept of bioabsorbable staplers, almost all staplers are using titanium, an inert metal, but would there be benefit potentially in terms of healing, stricture formation to go to something that's bioabsorbable like we've seen with meshes? Increasing articulation beyond 180 degrees, flexible staplers, things that can be used in third space surgery. And then really, I think we're going to have ever increasing smart technology. The kinds of platforms we're using in combination with the staplers have a tremendous amount of data that they're collecting. And I think this will be probably where we see the most advantage in terms of how these staplers are performing and really getting to precision surgical firing for each patient. Or perhaps we're going to be replaced by magnets altogether. Thanks, and happy to answer questions in the Q&A.
Okay, well, thank you, Tony. That was great. I'm going to start again, taking chairman's privilege. I think I know what you're going to say here, but what of the developments that are there, what do you think is the most exciting development?
I'm curious what you think I'll say. I think there's two. So I think the smart technology is really where we have the most improvements to see still, and also we'll get the most gain from, right? How many of us doing complex revisional surgery sit there trying to figure out what staple load to use, right? Like, should this be a green? Should this be a black? Should this be this, right? And you're using your, multi-thousand case history to try to help you figure that out. But it really would be best if the device, closed, this is the right one. Perfusion, I think that's another addition, that they've talked about adding, is that can not only thickness, but perfusion of the tissue, right? So you can tailor where you're placing that stapler based on best perfusion. I think that's another awesome advantage that we're going to start seeing with smart technology. And we see some of this particularly, I think, with the robotic stapling platform, that delayed compression, delayed speed of the sled being pushed forward to try to maximize the staple line formation. And so to me, that's the biggest advantage.
Yeah, I agree. I think the perfusion one's an interesting idea. But I think sticking to this theme of the smart stapler for a moment, I mean, as you sort of alluded to, we use our experience to make some of these judgments. We also use tactile and auditory feedback at the moment. If we're using a powered stapler, very often the strain in the motor is a little clue to us as to where the thickness of the tissue is sitting, and we can use that to anticipate whether we maybe need to increase our staple size for the next firing, and so on. So that's all, I guess, surgical experience, surgical art. Thankfully, there does seem to be a fairly wide tolerance. The smart technology, like all of these smart technologies, I'm going to use the analogy of the self-driving car, create, let's say, liability dilemmas. So you mentioned saying, well, it's only as good as whether we use it or not. What if a smart stapler gets it wrong? What's the implication of that from a medico-legal point of view? I suppose conversely, what if you ignore what it says because what you're seeing with your eyes is different, so you do the opposite? Well, it's a philosophical question. Any
It
thoughts
is,
there?
but such an important one, right? And I think as we integrate AI and smart technology more and more into our daily practice, it becomes a really important one. Ultimately, for the near and probably midterm future, the surgeon is responsible for the last decision. But I think you're right that if the technology is telling us don't go forward, right, and we override, and then a bad outcome happens, we're as liable as the converse to that when the device is giving us information that we decide I know better. And I think that's why I made that comment, because I think right now we sit in a space with the level of quality of smart technology that it is still needing us to use surgeon experience to interpret the information that we're getting and make the ultimate decision. As that technology improves, opportunities for us to do that will probably decrease, and that may actually put us more at risk, right? Because we're going to have less experience to tell us something doesn't seem right here. You made that comment about the auditory, the tactile feedback, right? When you put a stapler on something and something just doesn't feel right, and how many of us have had that be, my gosh, an intergastric foreign body or something where just you've saved yourself a big problem because your spider sense told yourself something isn't right here. And
something isn't
smart
right.
technology might decrease that a little bit.
Yeah. Well, I guess it would be good if the smart stapler told us the nasogastric was in the way.
It sure
That would
would.
be handy.
Foreign body present.
Yeah. Before I throw to the panel, there is a question from the floor. It says, what's your best strategy for managing a stapler misfire? For example, in the cases that you presented.
Yeah. Oh my gosh. Right. It's nice to have those on video, but it's still hard for me to watch those. So the first one, I think those of us who staple a lot, when you pull the stapler away and there's significant bleeding, that's probably a staple line malformation. So I put full thickness, serosa to mucosa top layer, mucosa to serosa bottom layer as 3 stay stitches. And luckily I had enough room to staple forward. And so just cut out the bad staple line. I actually did, even though it looked completely formed on the remnant side of that sleeve, I cut that out too, but just because I wasn't feeling comfortable. Something bad had happened with the stapler, and I just wanted to make sure we had clean staple lines. The robotic one happened very early in my robotic learning curve. And so I took a pause, went to lap because I felt much more comfortable with being able to correct the mistake there. And I think you have 2 options. A sleeve is a little bit tricky. You don't always have the ability to tighten up on that sleeve staple line. In this case, we did, because it happened mid-fire, and so we just angled a little forward. I will tell you that patient did develop bad GERD, and ultimately 2 years later, I converted her to a bypass. But that would be your bailout maneuver, I think, in that situation. If you felt like you couldn't continue with the sleeve, that you could convert that patient to a Roux-en-Y gastric bypass. The part that makes me nervous about over sewing an injury like that on a sleeve is the potential leak rate that you might have in a high pressure system. So I think you have to be very, very cautious about trying to recover staple line malformations on a sleeve.
Yeah, I'd agree. I agree with that, particularly if it's a long dehiscence. If you've just got, a very short area that you're concerned about, you can stitch that, but a long one is a bit trickier. And I would just want to emphasize and second what you said about a sleeve not really having as much room as, say, a bypass pouch to restaple. If you pull on it, it will look like you've got room because there's elasticity there. But when you let go of that, it's going to narrow. So you have to be very judicious about restapling and particularly if you're near the incisure, particularly, or at the angle of his for that matter. So yeah, proceed with caution in that regard. I agree. I'll throw now to the panel to Suthep. Any thoughts or reflections or questions from you on this one?
Thank you, Tammy. I wish that the smart technology will be available soon, but could you give us a little bit more in terms of the material that the bioabsorbable? Would you think it would be beneficial? And if it the direction that the technology will be invested in this part?
Yeah, personally, I don't know. I think titanium is a reasonable substance to use, and I read a couple things that have been in PubMed about case reports trying to develop biomaterials, a lot of them kind of within the polygalactol galactine based products. I think the potential of maybe adding in something that's coated with the antimicrobial, right? So you get some other things that you can do, I think, when you're using bioabsorbable staples or sutures that you don't necessarily can't implant on titanium. I haven't seen these technologies move far forward, and truthfully, I don't know if we have a lot to gain with using them or not, because I don't see a lot of challenges in my space with titanium staples.
Yeah, thank you very much.
Dr. Shah, any questions?
Yes. Oh no, just a comment. I think I saw that dreadful case of stapler line misfiring, and that can be because of maybe mechanical failure with matching between anvil and the cartridge, or maybe choice of the color or thickness. So what we generally follow whenever this happens, we try and staple medially with a new gun. I mean, we don't use the same device, even though most often one can use that. But if you have second accident, then there is very little for you to correct. So we use a new gun. We use one step higher, and if there is space available, otherwise we suture it in two rows if that is not possible, and maybe if possible, glue it with a fibrin sealant glue. So that is what we do. That's just
I
a
think
tip for beginners, unfortunately, if it happens. And before you do that, we remove all those loose pins which are lying in that area so that they don't interfere with the new blade action.
Yeah, that's a good point. In fact, just as good stapling principle, any loose staples, particularly in the crotch of the staple line you just made, you need to remove so that it doesn't impair the sled of the stapler going forward. Professor Kim.
Thank you for your nice lecture, and I have two questions. First question is, in the US, the robotic surgery is increasingly being used for revisional surgery. So does this trend include an expectation that robotic staplers will provide better clinical outcomes in staple line integrity compared to laparoscopic staplers, especially in complex tissue environment for revisional surgery?
Tough and a loaded question. So I've used both platforms. I will say I actually am primarily a laparoscopic platform, and our hospital has contract with the Ethicon stapler, so that's what I'm most familiar with. In the U.S., robotic bariatric surgery in particular, has a ever increasing utilization rate. Is the stapling technology better? I think there are strengths of both platforms, and I'm a big believer that ultimately what makes the outcome the best for the patient is your experience with the technology you're using. So the way I think that the U.S. educational system has been set up for our residents and our fellows, they're getting a lot of robotic exposure, particularly in bariatrics. And so when they go into practice, that is what they've been trained with. That's what they're most comfortable with, and that's what they're using. But I think when we go down to hard evidence and literature, it's tough to find, consistent evidence suggesting one platform is better than the other.
Yeah,
Okay,
go ahead. Yep.
Yeah. one more question. This question might be a bit of a silly question. In my experience with the sleeve gastrectomy, I've often thought that a curved shaped stapler would be superior to linear one in preventing gastric angle stenosis. So have you ever been any significant advancement in developing curved staplers?
A curved stapler.
Yeah,
Right. The challenge with curved staplers, I think, is it's likely limited to one angle, one curve of that angle, right? And so do you want that to be the same every time? I think the other thing that they have found challenging with doing that is trying to get the sled and the knife blade to push correctly through that curve and then back into the hood of the stapling body. So much like you, though, I tend to make my sleeve gastrectomy, even though each step is linear, it isn't a curved configuration altogether. As you know, there's now a stapling device that does the entire sleeve, and that's completely linear, but I prefer a more gradual curved shape myself.
Thank you. Yeah, that's good. We do have another question from the floor, which actually I think is a good one, and you kind of just hinted on it at the end of your presentation. Question is, do you think the future of tissue approximation will be in stapling or another kind of technology like tissue fusion with an energy device or glue or magnets?
Yes. Well, I said it kind of jokingly, but maybe not, right? I have no disclosure to give for magnet technology. I think it's a disruptive technology, right? It's a really exciting way to think about doing surgical anastomoses than what we have kind of previously been thinking about. I think the current technology is challenged by how many magnets can you put in right now, right? You can do one anastomosis at one time. You can't. So I can't imagine quite what that technology is going to look like to allow us to do our complex cases that are requiring multiple staple lines, multiple anastomoses in a system where you're limited by the science of magnets. Really, it's not safe to have multiple deployed magnets. So I think it could take over parts of the case. Excited to see what the long-term data is going to look like for safety. Also, we're challenged a little bit right now is how are those procedures replicating our standard procedures, and we need to get long-term data on that. A bipartition type of anatomy is different than what we normally do, and so we need long-term data on durability and metabolic outcomes. But I love the technology.
Yeah, we all like playing with new tools.
Yeah.
And on that note, we'll end the webinar. Thank you very much. There's been some really stimulating discussion. Thanks to all our guests and speakers. And for everyone that joined at home, have a good morning, afternoon, or evening, depending where you are. And we'll see you next time. Thank you very much.